Welcome to Alabama EMS Challenge. We're in Troy, Alabama at Hawkins Hall. I think that's where we're at. Yes, no, maybe? Yes? Sweet. Cool. And we'll get started. My name is Will Ferguson. I'm an ER doc out of Birmingham, Alabama. I'm the BRIMS medical director, work with several fire services, but the Alabama Fire College sponsors us to go out on the road once a month now. We're here in Troy. We came here last year as well, so thanks for not kicking us out and letting us come back. Sweet. All right. We'll get started. EMS Challenge was started back in 2014 with the goal of bringing physician-led free con ed to EMS agencies. We started at Jeff State Community College. We've grown from doing 1 day a week down at downtown Birmingham to doing this twice a month on the road with the support of the Fire College. So really grateful for their help as well. For your certificates today, you can use the chat feature if you're online to get your con ed. You fill out a QR code there. If you're in-house, you can scan the QR code on the tables and get that, fill out the survey. If you can't do either one of those, email us at alabamaemschallenge@gmail.com and do that by this afternoon. We'll get your con ed to you. We give con ed for both EMS and nursing personnel as well, so we can do both. If you're in the Troy area from noon 30 to 2, we're going to be doing skills labs. We'll do some surgical airways and some pig trachs. We can do advanced airway. We can do some megacode scenarios. I've got an ultrasound we can trial as well. And there's something else I've already forgot. What else we're doing? Anybody remember? No? Yeah. Yeah, that's about it. Maybe Jeopardy or something. I don't know. Sweet. All right. I wanted to go over a couple things and do some 12 leads, but I want to talk about the protocols as well. The protocols came out in April. It's some pretty interesting stuff. I know everybody's already had the protocol update. Just for those that have not looked at this, for any of the hospital staff that are watching, we've changed our complete format to kind of a flow sheet. Remember that the protocols are combined, general protocols and critical care all in one book. So don't get confused to think you can do critical care things. If you're not a critical care agency, they'll end up biting you. But if you look to the left of the boxes, it tells you who can do it. So IV access can be done by the advanced, the intermediate, the paramedic or critical care, AIPC. Cardiac monitored by the intermediate, the paramedic, or the critical care, and it kind of gives you the flow sheet or the way that works. When you look at the scope of practice for our EMTs in our state is a little bit more advanced than others. We're allowing folks to do blind insertion devices, iGels, Kings. They can also transmit 12 leads. With our staffing issues, we have a lot of BLS agencies that don't transport. Stroke scene, run a 12 lead and send that in. All right, and determine then if they need ALS care, transport, or they go into a STEMI hospital or not. Are y'all using blind insertion devices down here? Which one do y'all have? The King Airway, y'all still like that? Yeah, King is good. I'm an iGel fan. I don't sell them, but either way is fine. I like the iGel because it's almost redneck proof. There are no balloons to inflate. It's just basically you lubricate it and shove it in, and it usually works pretty good, but Kings are fine too. Other things that our EMTs can do is CPAP or BiPAP if you have a ventilator, and then capnography. So if you look at general scope of practice, this is a lot higher than some of the national standards. And my point to this statement is if you as an advanced or intermediate or paramedic are working with these EMTs, make sure you train them, okay? Don't just throw them in the back of the rescue to take care of the patient so you can drive. Actually explain to them what's going on, how to do these things. It's pretty important. Are y'all completely staffed here at Troy? Have any openings whatsoever? You do have openings. Yeah. It's like everybody else, right? So staffing is an issue. In the past, we kind of abused the EMT some, right? We can't do that anymore. We need those guys to be our backup. We need to get them excited about healthcare and get them to become paramedics. How many EMTs do we have here? How many EMTs are going to go into paramedic school? There we go. All right. Yeah. See, you like that, Chief? That's good. Good. Yeah. All right. All right, I'll quit rambling. Medicines the EMT can use now no longer is that you can assist. They can actually give these medicines. So Tylenol, albuterol, or the Duanebs. They can actually give aspirin now, glucose, and Narcan. So pretty big scope of practice for a 1 semester course, which is 140 hours, and then 48 hours of clinical. So the advanced EMT, are y'all working with advanced EMT here at all? You have some advanced? Yeah, so this is pretty cool stuff here. So there are a lot of places I'm working with now that we're going to ALS engines, and our ALS provider is that advanced EMT. They can do IV access, they can do IOs, and their medication list is ginormous now. It's kind of a big deal, right? So they can give anything the EMT can give. If your medical director approves it, we can even do antibiotics now. So Ancef, Rocephin, both approved for use. They're optional. My thoughts on that, if you have somebody with a nasty open fracture, a couple of grams of Ancef is probably beneficial. The sooner you get the antibiotics, the less risk of a bad outcome for those folks. The Rocephin or ceftriaxone was put in for sepsis. I think if you're going to be carrying that and using that as an advance or even a paramedic, you probably ought to discuss it with the hospitals that you transport to make sure they're good with that. There's some measures the hospitals have to do with sepsis. And if they don't meet those measures, they cannot bill Medicaid, Medicare. And if you take away their money, they will get aggravated with you. So I would discuss that with them before you do it. But Ancef is reasonable for the open fractures. The big thing for the advanced EMT is the epi. So they can give epi 1 in 10,000 in cardiac arrest now. Do y'all have an advanced EMT that works alone, have their own bag, or are they riding with a medic, or how does that work around here? 99, okay, fair enough. So cool. So my thoughts on that would be if you have advanced EMTs that have been trained to understand how to use the epi, have them draw it up and start giving that so that as staffing issues continue to go south for all of us, if you have an advanced out there as alone, they understand the concept, when to give it, how to use it. But this kind of moves ALS into the forefront with these advanced EMTs giving that. Glucagon is optional. Cyanokit, pretty expensive, about $900 to give. But for cyanide poisoning, it's the only thing that's going to work for that. My thoughts, if you work at a fire-based agency, maybe you buy one kit, keep it on your supervisor or battalion chief's truck. That way, if one of your guys or somebody's in a house fire, you're concerned about it, you got it. There's no way to stock that drug on every rescue or every drug bag. You would go broke doing that. Methylprednisone is not an optional drug. It's a steroid. The advanced EMT can use that. My thoughts on that is it can be used for two things. If I've got somebody who had anaphylaxis that I'm giving IM epi to, the next thing I'm doing is I'm starting the line, I'm pushing Benadryl, and I'm giving them steroids, okay? If I have an asthmatic or a COPD patient who's working hard, increased working breathing, and in my thoughts, I'm thinking they're sick as dirt, and I'm giving them 2 or 3 nebs back to back, I'm starting the line, and I'm gonna give them some Solumadrol as well. If they're pregnant, you wanna avoid it unless you think they're gonna die in front of you. If they're a diabetic, you wanna avoid the steroids as well. It'll make their sugar go up. And unless you think they're about to die, then you say, forget it. I'll fix the glucose at the hospital. They get the steroids. Versed is a scheduled drug for seizures. In the past, the advanced EMT would recognize somebody had a seizure. They would open the airway, give supplemental oxygen, ventilate, check a glucose. If it's low, they fix it. If it's normal, they leave it alone, and they just watch them seize, right? So now you can actually give some Versed for this. So nasal Versed, great news for the advanced EMT, but it also, remember, when you give somebody Versed and you stop their seizure, now they've had Versed and their postictal, big risk for loss of airway reflexes. So you got to make sure your advanced EMTs know how to manage an airway with an ambu bag, an OPA, and nasal trumpet, whatever it takes. It's poor form to stop a seizure, and then someone die because they quit breathing, right? Kind of defeats the purpose. Toradol. Toradol is a fantastic drug for some patients. Toradol is a non-steroidal anti-inflammatory. You won't get addicted to it. You're not giving somebody fentanyl or morphine. The problem with Toradol is that it's really bad on the kidneys. If you have older patients, older than 60, I would say no Toradol for them. If you have anybody you think has kidney problems, I say no Toradol for them, okay? The state says you can do 30 or 60. Where I work, I tell folks we're doing 15 max IV and 30 IM, okay? What people in Alabama have kidney problems? Obviously, the folks with the shunt in the arm. Well, other people have kidney problems in Alabama. I gave it away. Yeah, anybody that's diabetic, anybody with hypertension is high risk, anybody that's obese. You ever see anybody that has those problems? Yeah, every day, right? I see them in the mirror when I look at them, right? That's kind of funny. Thank you for almost smiling. Other thing for Toradol, a lot of folks I've been seeing are giving Toradol for trauma patients because they want to give them an opioid to kind of make them altered. I would not be giving Toradol to somebody who has risk for hemorrhagic shock. Toradol can make you bleed. It's probably not a good idea. I would say either break out, get a medic and break out your fentanyl or your morphine, or no Toradol, okay? Toradol is probably not good in hemorrhagic shock. The other cool really drug we got for advanced EMT is optional, but I'd advise that you get it, and that's TXA. So TXA is a great drug for hemorrhagic shock. The dose is 2 grams. State says over 20 minutes. There are some states where agencies are giving this IV push. The only risk of giving it fast is hypotension. I'm not saying it, give it IV push or give it fast. I'm just saying that some people are doing that. The only contraindication in TXA would be they aren't bleeding out and they aren't dying, and it's been more than 3 hours. So state used to talk about you can't give it to people with color blindness, other issues. That's all junk. The only risk would be if they're not bleeding, they don't need TXA. If they have anaphylaxis to it, they don't need TXA. Otherwise, you're pretty good. What's the lowest age limit you can give TXA to? Anybody know? 15. Yeah, 15. Yeah. What do you do if you got a 12-year-old that is 6'2", 140 pounds, and they're bleeding out? You call for orders or you don't ask their age, right? Yeah. That was funny. Not funny. I was joking. Crap. That's a tough crowd. All right. Medics, scope of practice. A couple of new medicines, 3% saline. Are y'all carrying 3% saline? Yeah, it's used for head injuries, kind of replaced the mannitol we used to use. I'm not a big fan. I know the trauma centers use it. I think risk to benefit, the cost is going to outweigh the benefit for most places. Calcium chloride is an optional drug. I would argue that you carry that. Calcium chloride is used for hyperkalemia, which is related to kidney disease. And we've already stated that a lot of folks in Alabama have kidney problems. So calcium chloride is a staple in my cardiac resuscitation. So I believe in that. What else we got? The state says that starting in January 23, everybody's going to either have morphine or fentanyl if you're ALS2, okay? Or ALS1, sorry. Yeah. 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 So, yep. So your med control doc will have to have a DEA. If they're already running ALS, you got to have a DEA number to carry the Versed and the ketamine. So it's not a big change, but in the BRIMS region, if you need help, reach out to me. I'm happy to help find somebody to get that for you, but it is required. We're going to talk about this as we go along. A new protocol, post-intubation sedation. This is somebody potentially out of hospital cardiac arrest that you intubate, you get ROSC on them. Now they're chewing at the tube. A lot of the older school medics would say we extubate them because we can't keep them down. In reality, if you got somebody intubated in the field, you want to keep that tube. So if you intubate them, now they're awake, they're looking at you, they're chewing at the tube, they're trying to beat you up. The state says you're category A, you can sedate them. You can use your fentanyl, your Versed. Nobody has Ativan on back order for everybody, or you can use ketamine. These are your doses. So know how they work, know when to give them. If you had a guy that was a heroin overdose that you gave 8 of Narcan to, started CPR, intubated, 1 round of CPR and epi, now he's alive. If you give him fentanyl to sedate him, is that going to work? No, you just gave him 8 of Narcan, right? So that dude, okay, I'm going to give him either Versed or ketamine. All right. If I had a guy that just had a big freaking VFib arrest and a STEMI, I shock him, he wakes up, he's chewing on the tube. I'm probably not going to give him ketamine because that's going to make him get tachycardic and hypertensive, which is bad for him. So I'd give him a whole bunch of fentanyl. So you got to understand which drug to use for that. But it's great for you guys. It allows you to get out there and actually practice the medicine that we already know you do. And then the last thing we'll talk about the protocols, I think, is syncope. Remember, people that fell out, that passed out, that syncopized, one of the leading causes of that is a dysrhythmia or a STEMI. So any syncope, any lift assist that you go pick somebody up on, I recommend taking a few minutes to do a 12 lead, okay? Yep, you may do 90 of them before you catch something bad, but when you catch something bad, you're gonna save somebody's life, and that's why we're there. So syncope is a very concerning thing. I get it. We all see people that pass out for no reason, that fake it, that get too hot, they pass out, they had too many PBRs, right, and they pass out. But if you don't do the EKGs, you're gonna miss somebody having something bad that we can fix one day. Are y'all carrying gastric tubes here at Troy? G-tubes? So state says we can carry these. I think these are a great airway device. Anybody that I ventilate with a BVM, I'm gonna get air in their belly. No matter how good you think you are, you put air in the belly, big risk for aspiration. In kids, if you distend the belly, it pushes up the diaphragm. You can't ventilate them well. So I think OG tubes are airway management device. The places that I work with, I recommend getting just a couple adult sizes. You can put an adult, like a 16 or 18 gastric tube in a 2-year-old, okay? The trick is you measure from their nose to the ear to the xiphoid process, and you tape it off, and you put it in the mouth hole. and it decompresses the belly. Now you're going to have 8 feet of tube sticking out the end. That's fine. The whole thing doesn't go on. It'll come out their backside. You get in trouble for that, right? But the diameter does not matter. So G-tubes are great. There have been kids that I've had difficulty managing the airway by intubation. So screw it. I put an OPA in, I put a gastric tube, and I crank them back, and I ventilate with the BVM. It works pretty good. It's like cheating, and I like to cheat on airway management. That's not funny either. This is the iGel. Not sure if this video will show up. There we go. Can I touch the screen, Chief, or is that dangerous to touch the screen? Oh. All right. That's a cool little video. It shows how iGels work and how simple they are. It's lubricate it, slide it in, hook it up. And the key thing is, if you're working at an ALS agency and you put an iGel in somebody, you should use capnography. Capnography works on iGels. If you're not getting capnography, if your SATs don't work, something is wrong. The iGel is not working. Take it out, do something different. And we're going to play with some of those things in the airway lab today as well. You got to get capnography. Now, if you're a BLS agency, you don't have waveform capnography, hey, no harm, no foul. It is what it is, okay? Use other things to assess your patient. Is the chest moving? Do the SATs get better? Do they start getting pink again? Is the blueness going away? All right? But at the advanced or paramedic level, we should be throwing waveform capnography, okay? Again, these are almost idiot-proof, almost. I've seen them go in upside down. That doesn't work. You usually figure it out about a second squeeze when the vomit flaps back in your face, right? I've seen them go in, they get stuck on the tongue, and they try to force them in. That doesn't work either. And I've seen them lacerated by tongue rings. That doesn't work either. But for the most part, these are pretty idiot-proof. We don't want sound. It's in a different language. Nope. All right. So, all right, just some other thoughts on your 12 leads. When you do a 12 lead, even if you have a place to document and you drop down PCRs, I recommend put it in your narrative. 12 lead done at whatever time you do it, you know, sinus rhythm rate of 80, and then put STEMI or no STEMI. When you think about medical legal stuff, if I was reviewing a case and I had a patient who had some kind of cardiac event, and I look and I see that you documented the 12 lead, I'm probably going to say everything is good, even if it changes later on. But if you don't document what you see on that 12 lead, that's where you get bit. It doesn't have to be fancy. You don't have to get in the woods. Just the rhythm, the time, the rate, and do you think it's a STEMI or not STEMI? Yes, sir, sure.
In the last probably 2 months, we've had 4 cases where agencies don't change the time in their monitor. So their 12 leads, when it goes to these facilities or PCI, they have to do STEMI reviews. And when they do those clinical reviews, we got to track down time. So always remember when time changes, it's like checking your smoke detector, change your monitor times.
Right, yeah. And we have the same problem at Brent's, the monitor times. And the reason that's important, I know you're thinking, why do I care what the hospital thinks about times? And the reason is the hospitals are actually getting excited about our EMS documentation now. And if they like our documentation, we're talking about data exchange. That way you'll be able to log into their system, do follow-up on your patients, or maybe they have an old EKG in the system you can look at while you're on scene. So the more they like our documentation, the better it is for us. So I'm like you. I tell my guys, please, in the narrative, put the time, the rate, the rhythm, and say STEMI or no STEMI. It just keeps us out of trouble. Capnography, there should never be an intubation that you do that does not have waveform capnography documented, both that you see a waveform and a number. I can tell you, even if your tube is perfect, even if you got a video scope and a picture, if you get to the hospital and the tube's in the wrong hole, and you don't have this documented, you will get some negative feedback, all right? The other thing is, I don't care who you are, if you intubate long enough, you will put a tube in the wrong place. That's fine. We all do it. What kills people if you don't recognize it, okay? So you got to document capnography. Narcan, be advised, Narcan is getting hard to find. The price is going up. A lot of drugs are doing that. My thoughts on the Narcan, nasal Narcan in cardiac arrest does nothing. If the patient has no pulse and they're dead, they're not going to get perfusion to the nose. I think if someone's in cardiac arrest, even from an opioid overdose, you bag them, you manage the airway, you push epi. If you want to give a dose of Narcan IV after that, yeah, give it a shot. But nasal Narcan does not work in cardiac arrest. We've already talked about Solu-Medrol and Toradol. The death in the field stuff was something I was going to talk about, the Broom Ranger. Anybody know who this is, what song this is from? If you do, I'll give you a challenge coin and $1. Oh, there you go. Yes, sir. Yeah, okay, good. You get $1. All right. That's right. That's good. Yeah. Yeah. Sweet. All right, so let's talk about some EKGs. Original concepts of EMS was 3 leads. Paramedicine has always been the gurus of 3-lead interpretation. Junctional rhythm, bradycardia, tachycardia, SVT. That's got to change. When EMS was initiated, there was no treatment for STEMIs. It was, yep, you're having a heart attack. I'm going to hang some lidocaine, so if you go into VFib, maybe you won't die. I'm going to give you bad food, tell you to quit smoking, all right, and we'll call it a day. We can actually fix these things now. Take somebody having a big STEMI on Monday to get in the calf and back out drinking beer, smoking, and playing football on Saturday the next weekend. So we've got to be able to interpret 12 leads, all right? My thoughts on 12 leads is not this. A 12 lead is a screening tool. It just gives you some data. STEMI or no STEMI, sick or not sick. I get it. We all learned about vectors and things of that nature. I cannot remember vectors at 2 o'clock in the morning or even at 9:20 in the morning, right? So I look at 12 leads. Are they too fast? Are they too slow? Or okay-ish? Too fast? I like American Heart. Is it wide or narrow, regular or irregular? Too slow? I think about 3 things that cause it. It's drugs, electrolytes, or ischemia. Anything else you pick up with your primary exam, right? So if I got a dude shot in the belly whose heart rate's 140 and now he's sweaty, gets confused, heart rate's 120, 90, 70, 30, 10, what's going on with him? He's bleeding out. He's dying, right? I picked that up. I don't need the 12 lead to tell me that. He's dying. He needs TXA. He needs blood and a surgeon, right? If I got a 6-month-old that's blue, breathing 2 times a minute, heart rate of 40, what's going on with them? Respiratory, right, yeah. So those things you kind of pick up on your exam. 3 things you won't pick up by your physical exam will be drugs. Are they on a beta blocker or a calcium channel blocker? Did they miss the dose, take too much? Are the kidneys jacked up now and they can't clear it? Electrolytes, which is hyperkalemia. Hyperkalemia, regardless of what they say in the literature, is prevalent throughout the Deep South for the reasons we already talked about. And then ischemia, which is a STEMI or some kind of underlying heart problem. All right, the rates that I use for this is 50 to 150, so greater than 150 is too fast, 50 or less is too slow. Anything in between is okay-ish, and it's either complicated or it's not. It's a STEMI, it's not a STEMI, maybe it's a tricyclic antidepressant overdose. We're going to talk about functional use of AVR over the course of the year. Then obviously we're going to push really big for STEMI versus no STEMI. So you got to be able to calculate a rate on paper. Do not trust your machines. You can look at those numbers, but always double check it. I use the box method. So from QRS to next box is 300, then 150, then 100, then 75. Then I'm thinking about fishing, thinking about going home. I want a Monster energy drink. When I get to box number 9 or 10, I know I'm way too slow. Intervals, you got to know your intervals. If you don't know what a QRS complex looks like normally, you're not going to know is it wide or narrow in SVT or VTAC, right? The QT interval is very important. It should be less than half the R to R interval. And then we all learned in medic school about the PR interval. What does a prolonged PR interval tell you? First 3 heart block. And does that matter in patient care? No, it does not matter at all. It's like, yeah, you got a first 3 heart block. Who cares? Doesn't change anything. A prolonged PR interval in the setting of a wide QRS makes me think hyperkalemia. They're probably going to be bradycardic. So that's why that PR interval is important, okay? Wait. So this one, too fast, too slow, or okay-ish. I say the rate is okay-ish. All right, so the next thing I'm going to start doing is looking at injury patterns. I'm going to look at leads 1, AVL, then 5 and 6. I'm looking for ST elevation. That'll be a STEMI if I get it in 2 of these. Or maybe I got T-wave inversion. That makes me think some kind of underlying ischemia. Makes me uncomfortable, but it's not a STEMI. So 1, AVL, 5 and 6. Then I look inferiorly, 2, 3, and AVF for the same thing. Is that screen moving or is it just me? Good, good. I thought I was fixing to have a seizure or something. I was going to lay down. Wow. I did have Waffle House this morning. I'm high as a kite. Man, that waffle was good. So 2, 3, and AVF. The next thing I look is V1 through V4. I'm looking for ST elevation. You're looking for, textbooks say 1.5 to 2 millimeters elevation is what you're looking for there. Those are your septal and anterior leads. V1, V2 is septal, 3 and 4 is anterior. The next thing I think about is looking at V2, 3, and 4, and I'm looking for ST depression, T-wave inversion. That's a posterior infarct, because if those are the anterior leads, if you got depression, it's posterior infarct. The backside of the heart's having some issues. And the last place I look is lead AVR. If I have elevation in lead AVR, and I have ST depression anywhere else in the injury pattern, such as 1, AVL, and 5 and 6, or 2, 3, and AVF, I'm thinking about a left main disease. That's a STEMI equivalent. Okay? The machine is not going to read STEMI. You're going to have to recognize, holy crap, that's concerning. All right? And that's the one that you call and you talk to your hospital. I'm not sure how your STEMI system works in this area yet, but this is one that you make sure that the hospital knows you're concerned about a STEMI. This is one that when you get to the hospital, you take this EKG to the doc, you say, hey, dude's having chest pain, this is the EKG, and make them aware of your uncomfortableness of that EKG. So I go through all those leads, and now I'm gonna look for intervals, right? So I'm gonna go to lead 2. I'm gonna look at my QRS, is it wide or narrow? That one's narrow. I'm gonna look for my QT interval. I'm gonna look for my P wave, my PR interval, okay? If that QRS is wide, I got to determine, all right, well, crap, that changes everything. This is a bundle branch block. So then I go to lead V1, and this cell determine is it a left bundle or right bundle. So I go to V1. If it points down, it's a left bundle. If it points up, it's a right bundle for the most part. All right, I've done all that. And before I put that EKG back down, I'm going to go back and, again, one more time, look at injury patterns, because there's some days I'm really tired and I miss things, and I do not want to miss a STEMI, because that changes the flow of patient care, and people die when you miss those things and you feel bad about it. So this one has a Y complex QRS. I go to V1, it's pointing down. This is a left bundle branch block. There are a lot of causes of a left bundle branch block. They're acute and chronic. We used to say if somebody had chest pain and a left bundle branch block and you couldn't get an old EKG, you thought they were having a heart attack. Probably not the case. It went away from being a STEMI equivalent in 2013. However, that being said, if you have somebody having a left bundle, their chest is hurting, they're sweaty, they're diaphoretic, they're obese, they're hypertensive, they could be having a heart attack, right? So lots of causes: hypertension, chronic drug use, and anything that causes the heart to enlarge will make these pathways stretch, and you get a Y complex QRS. And again, I'm not going to discuss vectors because I would fall asleep myself. The way you determine if it's a left bundle, you got a Y complex QRS, you got a Q and V1 that's pointing down, and then I got also look in AVL and make sure there's no Q in AVL. The textbooks give you a lot of ways to determine if it's a left bundle or right bundle. A lot of things you can look at. Again, I use the EKG as a screening tool, so I use the V1 down versus up, Y complex QRS. There's something called Scarbosa's criteria. This is the way you can look at a left bundle branch block to say, is there a new STEMI or not under this? Because obviously they have some underlying heart problems with the left bundle. Scarbosa's criteria is pretty simple. There's some new modified Scarbosa. There's some new things they changed. Keep it simple. Concordant ST elevation is bad. So QRS pointing the same direction as the ST elevation is a STEMI, whether you have a left bundle or a right bundle or a no bundle, okay? Concordant ST depression in V1, 2, or 3 is a posterior infarct and a left bundle or a no bundle. Discord's the different. Discordance and left bundle is great. So if you got somebody with a QRS pointing down and ST elevation pointing the opposite direction, as long as it's not bigger than one big box, it's probably okay. So again, discord is good. And that's for the guy that recognized LL Cool J. You probably recognize that movie too, right? All right, moving on. But that's Scarbosa's criteria. So this one, we would say the rate is okayish. It's not greater than 140. We'll look in injury patterns, 1, AVL, and lateral. We got some depression laterally, makes us uncomfortable. 2, 3, and AVF looks okayish. V1 through V4, we got ST elevation in 2, 3, and 4, and 1, excuse me, in 1, 2, and 3. So maybe thinking a septal or anterior infarct. I go look at AVR. AVR looks okay. Now I'm gonna go to lead 2. My peer interval is maybe a little bit long. My QRS is wide, so I go to V1. It points down, so I know it's a left bundle. So now I apply scarbosa, and I recognize that the only concerning thing I have is V1 through V4, but it's discord. So probably not a STEMI. Okay, if the patient still has concerns, if he's nauseous, if he's diaphoretic, having chest pain, he still gets IV access, he still gets his aspirin, he still gets his 12 lead, he still goes to the hospital, but I'm not as concerned. If that discord was 2 big boxes, he gets all those things, plus he makes me sweaty, I drive a little faster, and when I get to the hospital, I'm bypassing the nurses to go find the doc, hey, dude's having a STEMI. Does that make sense? And that's the reason it's important to understand how to read these things. The manufacturers will tell you that the 12 lead monitors for LifePak and Zoll and Tempest are about 90–95% accurate. I would say that's junk. I say they're not that accurate. A lot of the algorithms they use for when they get to a left bundle is the machine says left bundle and quits interpreting. That's where you have to go in and interpret it. So this one, too fast, too slow, or okay-ish? Yeah, it's okay-ish. Yeah, the machine says 93. We can trust the machine mostly with numbers, right? I look at my boxes, QRS, 300, 150, 100, yeah, 100 to 125. So I'm saying around that rate. They're saying 95, about the same. I'm gonna start looking at injury patterns. I'll look at 1, AVL, and 5 and 6. 2, 3, and AVF. I got some depression, T-wave inversion. V1 through V4. I got some pretty significant ST depression, T-wave inversion. So my first thought in my brain is, oh crap, this doesn't look good, right? So I go back to AVR. AVR is reasonable. Now I'm gonna go to lead 2. Peer interval is normal. QRS is wide. So I go to V1. And now I'm pointing up. So this tells me it's a right bundle. And there's some rules for right bundle too, right? So with the right bundle branch block, I should know that this is normal. So now I go back, I'm not as concerned, I'm not as sweaty, I'm not using profanity anymore. I feel better about this patient. The patient still gets the appropriate treatment if they're symptomatic. Aspirin, O2, IV access, 12 lead, transport to the facility. I talk to the doc when I get there, I show them the EKG, but my gestalt is, yeah, this is a right bundle, probably not acute infarct, okay? So 1, AVL, 5 and 6, just like anybody else. 2, 3, and AVF. V1 through V4, we talked about our concerns. I'm peeking at AVR. Now I'm gonna go over here. Intervals, I recognize Y complex. So it's a left or a right bundle or something funky. I go to V1, it points up. So it's not so funky, it's a right bundle. And I recognize the fact that that depression is probably okay. So what causes a right bundle branch block? Anything that jacks up the right side of the heart. So people who have chronic hypertension and get left-sided heart failure, get right-sided heart failure. They get a right bundle, okay? The more concerning things are things that can cause a right bundle acutely. So anything that causes increased pressure into lungs can make that right side of the heart swell up and you get a right bundle. So chronically, COPD, pulmonary hypertension, lung cancer, okay? Acutely, what I think of is a pulmonary embolism. So if I got a young person who is now diaphoretic, hypoxic, breathing fast, I do a quick 12 lead, and it's a right bundle on a young person. Why in the dirt does our young person have a right bundle branch block? Maybe they have something that increased pressure in the lungs, like a PE. So that's how you can diagnose those things in the field, even without an ultrasound or advanced imaging. Questions, comments, statements within reason?
To look at this, it looks like a bifascicular.
Yeah.
Do you put any weight in that at all?
You can. I'm trying not to get that deep into that. I would rather keep it. As far as for pain management, you mean?
Right.
No.
Like with a bifascicular not causing that last fascicule to relax.
Yeah, I would not be worried about that. No, sir. No, sir. Yeah. You see my eyes crossed when you said bifascicular? They did that. That's what they did. No, that's good stuff to understand, but I would not get that deep in the weeds with it. So a nice little schematic you can get off the internet that talks about ischemia. It shows how this works. The lateral is the left circumflex. The LAD is the big one going down the middle of the heart. The inferior is your right-sided. That's why if somebody has a right-sided infarct and we drop their blood pressure with maybe nitro, they don't get a good preload, they get hypotensive, right? And then if you look at AVR, the aorta is where both of the big vessels come off. So if you elevate it in AVR and down somewhere else, that's a sign of a very proximal occlusion of a left or right one. And those guys are in bad shape. I show this at most classes I do, and this is to show you that you cannot trust the machines. What's wrong with this picture of this monitor? Blood pressure. Can you have that kind of blood pressure? I don't think you can either. So remember, do not trust the machines, right? I show this as well. And then for those of you that are even older, we should have known from this movie not to trust machines, but in the Terminator and now this. Do not trust the machine. Wait. All right, so a case. 78-year-old male, fell at a nursing home, has got a head laceration, right? So what do you do for this guy? So I can tell you some folks say, pick him up. I like that. Very good. Yes, yes. Are you a fireman? I can tell. I recognize that gesture. Pick him up. Lift assist. Yes, no chart for you. That's right. No, do a chart, right? Yeah. So a lot of folks say, oh man, old man tripped and fell, not a big deal. Yeah, you don't trust old people, right? You don't trust them. Who knows what, especially, okay, I'm gonna get in trouble. Yeah, did he trip and fall? Did he syncopize? Did he done fell out? What happened? Nobody knows. Nobody's going to tell you, all right? Maybe he has some underlying dementia. I would say an old person that falls, you got to think about reasons they fall, right? So syncope is one of those reasons. So he's going to get a 12 lead. You can look for things that kill people. So I'm going to be doing my ABCs while I'm getting a history. Lean down, hey man, my name's Ferguson. What happened to you, right? Try to see, is he mentally with it? Does he know what's going on? What's a big history question I'm going to ask an old dude that falls and hits his head? What's an important history question? Who was the first president? Yes, praise God. Thank you, ma'am. Do you take a blood thinner? Yeah. I don't care if he has hypertension. He's 76. He's probably got it. I don't care if he's had heart problems. He's probably got it. He's 76. I care about, is he on blood thinners, right? He fell, he smacked his head, high risk for bleeding. So, hey, are you on blood thinners? Aspirin, Plavix, Coumadin, name them all, whatever you got. Sweet, yeah. And then ask him, why'd you fall? And if he says, well, I'm, just had surgery on my toe and I tripped, that makes me feel better. I still don't trust him, all right? Quick set of vital signs, my hands on his pulse. Is it regular or irregular? Is the skin warm and dry? All right. Blood pressure is 160/70, breathing fine, satin fine. He's neuro intact. I'm looking for stroke symptoms. Hey, raise your arms, give me a high five, roll tide, see what they say to that. They either say roll tide or they punch you. There's no in between, right? All right. Sweet, cool. And then we're gonna get his EKG. Too fast, too slow, or okay? Well, I say it's okay-ish. Machine says the rate is 89. I'm gonna say 300, 150, 100. Yeah, who cares, right? Not too slow, not too fast. I'm gonna start looking at injury patterns. So look at leads 1, AVL, 5 and 6, 2, 3 and AVF, V1 through V4. I go back up to AVR. I'm gonna go to lead 2 and look at my intervals, PR interval, QRS, QT. And then before I put the EKG down, I'm gonna go back and look at injury patterns one more time. Anything concerning on that 12 lead? What now? Oh, don't be technical. That's because you didn't change the monitor, ma'am. That's why. Golly, man. Tell you what, no coin for you. Yeah, who said that? Somebody. Wow, QTC. Yeah, look at the QT interval. Machine gives you a number, but I don't trust machine numbers. But if I look at lead 2, I got a P wave, and there's some dude buttoned up next to it. I don't know what that is yet. I got a QRS, and I go way, 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 way down. That's my T wave. So my QT interval is more than half my R to R. So I got a prolonged QT interval. So what does that tell you that could have caused him to fall? Yeah, maybe he's on the wrong medicines. Maybe he's on something that prolongs the QT. But what happens when you get a long QT? What rhythm do you end up going into off and on? Nobody's going to talk to me now. Kinda, yeah, torsades. Yeah, torsades, right? Yeah, if you go into, you have a long QT and you go to torsades and you fall over and you hit the ground and you come out of it, you call it syncope. If you have a long QT and you go into torsades and you fall over and you don't come out of it, what do you call it? Cardiac arrest. So this is a very high risk patient. You should look at this and you should be using profanity in your brain, saying, oh, shoot, not good. So now, even if he told me he tripped and fell and somebody watched him trip and fell, I don't care, all right? Now he gets pads on him, he gets IV access, and I'm thinking about treating this with certain medications, right? So we kind of talked about too fast or slow. He was okay-ish. Long QT leads to torsades. What drug do you give to somebody in torsades? Mag sulfate. What's the dose? 2 grams. How fast do you give it? As quick as you can, right. Now you ask our hospital. Yes, sir. Yeah. So the risk of giving somebody mag too fast is you drop the blood pressure. You'll see that happen if you're giving 4, 6, 8 grams. We're not giving that much. We're going to give 2. The hospital, the pharmacy, a lot of physicians, the nursing literature all state you give magnesium like 1 gram over 30 minutes or 1 gram over an hour. I got an old dude with a QT that's more than half the R to R, high risk for going into torsades and dying. He's going to get 2 grams of magnesium relatively fast. Okay. What drugs can you take prolong the QT? Amiodarone, right. So amiodarone was a drug of choice in the 2000s for VTAC, VFib, AFib, nasal congestion, everything, right? Somebody got rich off of it. Long-term amio use jacks up the lungs, causes pulmonary issues. It also prolongs the QT. Sotalol does it, all right? So somebody with underlying heart problems, history of AFib or ventricular dysrhythmias may have a long QT. What other drugs prolong the QT? What other patients? Zofran, yeah. So if this dude was nauseous and you gave him Zofran, what'd you just do? You fixing to run a cold, man. That's gonna be fun. Yeah, but bad for the patient. Good, Zofran, I like that. What other drugs prolong the QT? You say candy? Oh, okay, I thought it was candy. What did you find? Yes, antipsychotics. Any psychiatric medication is going to prolong that QT. Any of them. So patients that are high risk for having prolonged QT are homelessness, folks with underlying psychiatric disorders. Okay, people who are malnourished, get a low magnesium level, have a long QT. So if you have somebody who is chronic alcoholic, malnourished, and on psychiatric medications, big risk for that, okay? Yes, that's what I would do. Correct, they're not in torsades, but they're high risk, right? So it would not be kind to give mag for this. It's like, hey doc, I got a 42-year-old transgender guy who might be 76, right? Who passed out. His QT interval is 670. I'm concerned about this long QT. I'm gonna give 2 grams of mag. I'll see you in a few minutes. Thank you. Remember, when you call on the radio, we all have ADHD. We don't want a long history. We want it short and sweet. Tell me what you want, what you really, really want, and we'll give it to you. That's funny. Other drugs, cimetidine, erythromycin, antibiotics, a lot of the HIV retroviral medications, medicines for GI upset, Pepcid, Zantac do that. Benadryl prolongs the QT. So folks that are older on medications already that prolong the QT and they're taking over-the-counter antihistamines and Benadryl, big risk for going into torsades. Cool. We talked about treatment. It's magnesium. If they're in persistent torsades, they also get the electricity. All right. You already stole my Zofran joke. I had a psych patient in one of our rooms in the ER one night that was hungry, so I gave him a turkey sandwich. I went back to work a code, and I'm working one code. The nurse say, hey, dude in 14's in cardiac arrest. I'm like, dude in 14 got a turkey sandwich. He's fine. So I finally walked back to the room, and sure enough, they were coding him. The resident had given him some Zofran and for his turkey sandwich, because you got to have Zofran with a turkey sandwich, and went into torsades. He got some magnesium, some electricity, some plastic. He got a few days in the hospital, but he did fine. Cool. Next case, 62-year-old male, weak, nauseous. He vomited one time, a little bit sweaty now. So what are you gonna do for this guy? 12 lead, good. I'm doing 12 leads today. Very good, 12 leads, right? The protocols you state that you get 12 leads on people with chest pain. You get 12 leads on people with concerns for acute coronary syndrome, for people for concerns for dysrhythmia or syncope, for people who are concerned with certain drug overdoses. So 12 lead for this guy. Too fast, too slow, or okay? Okay. I'm gonna look at injury patterns. 1, excuse me, AVL 5 and 6. 2, 3, and AVF, my inferior leads. Somebody said ding, ding, ding. V1 through V4, then I'm gonna go AVR. I do every EKG the same way, even if I see a ding, 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 okay? I'm gonna run through this in my brain so that way it's always a habit, so I don't miss something when it's something that's not obvious. Lead 2 for intervals, then I go back one more time, look at 1, AVL, 5 and 6, 2, 3, and AVF, V1 through V4, and AVR. So I would say that leads 3 and AVF have some ST elevation. It's greater than a millimeter. It's concerning. If I go look at lead 1 and AVL, I got depression. We would call that reciprocal changes. And then I got an older dude who's puking. So that is a what? That is a STEMI, right? So this is somebody that in the past, we didn't intervene, we missed this, he's going to progress. These guys die of a couple things in the first few hours. They die of VTAC, VFib arrest, or congestive heart failure, cardiogenic shock. So we miss this, somebody dies. Did the machine pick it up? No, machine did not pick it up, did it? No, and this is a more expensive hospital machine, right? And it still sucks. So we have to interpret these things. So what do? There's MONA, there's FONA. Remember this, Chief Ward? I mentioned this last time, and I've already forgot what it stands. That was my mnemonic to use, so it's not a good mnemonic. Yeah, I don't either. So what's the first therapy this guy needs? That says mono. What do they need? What's the first drug they get? Aspirin. Why do they get aspirin first? Yeah, stop the coagulation. Hey, stop the clot from getting bigger, right? We can't dissolve the clot, but we can stop it from getting bigger, right? So aspirin. What's the contraindication to aspirin? What patients do not get aspirin? Right. If he says, I take aspirin, I swell up, they cut my neck. No aspirin for you. What if he said, I took 2 aspirins before you got here? What do you say? Here's 2 more. Here's the appropriate dose. I can't tell you how many times people take their Norco, their meth, their crack, whatever, thinking it was aspirin. I don't care. If you give a patient an aspirin, I'm going to trust you. I'm not going to repeat it. If the patient takes their own, they get an aspirin from one of us. So aspirin's most important. What's another drug we can give the dude? Yeah, so nitro, yeah. He is having an inferior infarct. I would argue that he gets nitro once you get IV access. Just in case you drop his pressure, you can fix that. All right, so I would do aspirin. Somebody's doing pre-oxygenation. Somebody's throwing the pads on him. Somebody's starting a line. Once that line is in, he's popping a nitro. Then we go from there. You can use morphine. Morphine makes you have chest pain, takes your chest pain from, yeah, I have chest pain, I feel bad, to, yeah, I got chest pain, but I don't care. The benefit to morphine is it lowers your blood pressure as well. Fentanyl is probably better. Fentanyl doesn't affect your blood pressure, but it also doesn't jack up the other medicines we give you in the cath lab to keep you from clotting. Okay. Yes, that is what it was. Thank you. All right, good. Right, yeah, that's my mnemonic. I'm going to patent that. Thank you for remembering it. So the SIT stands for suspect, right? Investigate and treat. Suspect for acute coronary syndrome, investigate it, get a 12 lead, and then treat with aspirin IV, nitro, ride the lightning pads, oxygen, and morphine. That's good, yes. So it's easy to remember. Yeah, that's right. The next tattoo I get is going to be on my arm, just like that. Yeah, see, there we go. Yeah. All right, y'all got it? Aspirin, IV, then nitro, ride the lightning pads, defib pads. If they're having a STEMI, they get defib pads. If they're having chest pain, they don't. You'll go broke. If they're having a STEMI, they get defib pads. So if they go into VFib arrest in the back of your unit going to the hospital and it's just you back there, after you cuss, you can hit charge to 200 and shock them as you yell for help to pull over. And maybe you fix them, and then you just keep trucking down the road. Thank you, Chief. Appreciate that. Remember, the aspirin just prevents the clot from getting bigger. It doesn't break the clot up. There's a checklist in the protocols for the state. It's a thrombolytic checklist. The STEMI hospitals have asked for everyone to fill these out and leave them at the hospital. I know nobody does that. I get it. But you got to ask these questions. And these questions are important because if your patient's having a STEMI and they go into cardiac arrest and you bring them to me in the ER and we're doing chest compressions, they've been shocked a few times, and I know they were having a STEMI beforehand, I can give them a drug, Retavase, TPA, TNK, and break it open that clot, potentially save them. But there's some patients I can't give that medication to. And if you don't ask these questions and understand that, I can't get that data. If dude has an aneurysm in his head, I can't give him a thrombolytic, even if he's dying from a heart attack. It's poor form, right? He's already dead. I know you can't get deader, but if I give him a thrombolytic, it's not good because now he's going to bleed in his brain and open up that heart vessel, and you die from that. If he's had a recent surgeries, okay? So these are questions you should understand, the absolute contraindications to thrombolytics and the relatives. Ask these questions to that guy as you're starting your second IV, as you're going to the hospital, and keep them in your brain. And then if you need to give that information to us at the hospital, give it to us. Write it down on a glove, on a piece of tape, on a napkin, give it to us, all right? Very important stuff. At the hospital, we can do a couple of things. If we can get them to a cath lab within 90 minutes, we're going to do that, or we go and put a wire in, put a balloon, inflate it, and fix that clot. If we can't do that, we want to get this thrombolytic on board within 30 minutes. And again, we can use the same drug they use for strokes, TPA. There's a couple other drugs out there. Retavase is a drug that's used pre-hospital. It comes in 10 units, or is it milligrams? I think it's units. But basically, you would go through the screening process in the field, not in our state yet. You'd recognize the STEMI. There are no absolute contraindications. You give a dose of Retavase as you go into the hospital. If they get better, you high-five your partner. They go to the cath lab the next morning. If they don't get better, we give them 10 more units in the hospital. If they get better, we high-five our nurses. They go to the cath lab in the morning. If they don't get better, they go to the cath lab then. But some states are doing that now. Oxygen. American Heart doesn't like O2 on people that aren't hypoxic. Fine, I'll agree with that. But I'd also argue that people die from STEMIs in the first couple of hours from cardiac arrest. And so I'm going to pre-oxygenate my STEMIs. So my STEMIs get 2 liters nasal cannula. And that way, if they go into cardiac arrest in the back of the rescue of the hospital, in addition to charging and shocking, I crank the O2 up to 15 liters. They got passive O2, all right? So that way I can put the mask over, I can ventilate them, do whatever I need to do. There's no data that oxygen short-term use is bad for people. 12 hours, 24 hours from somebody that's not hypoxic, probably not good. 45 minutes and somebody that's not hypoxic, you go to a bar in Denver and do that and drink a nice beer, and nobody dies from that. STEMI or no STEMI? STEMI, machine agrees. If you miss that one, it's time to invest in glasses or go work at Walmart. Cause of death, VFib, medic was sharp, had the pads on, charged, shocked them, and the person was cussing and mad when they got to the hospital. But you can't be cussing and mad if you're dead. So I give them a bunch of medicines, we sedate them, they go to the cath lab. Oh, there's my mnemonic skin ride to lightning pads. Thank you, Chief Ward. I got to write down what that means. Ride to light. This is just a, in the cath lab, the balloon is up. You see there's no ST elevation. Balloon is down. They're advancing it. STEMI. So STEMI's there, balloon is up. The heart gets perfusion, EKG changes go away. Pretty cool stuff. That's the cath report. These are much nicer when you can actually see the video. I can't get that type of video to play on my laptop yet, I'm sorry. But basically, they got a wire in there, they squirt dye, they recognize there should be a vessel running down here, there's not. So they follow where that vessel should be, put the balloon in, inflate it, put a piece of metal stent over there, anticoagulate the crap out of them, and then you see blood supply goes back to the heart, and life is good. Nice stuff. But it all goes back to this EKG. Had the person not recognized this, and this person spent 30 minutes on scene, getting a good history, getting the medicines in the Walmart bag, putting the dog in the backyard, locking up the fridge, and then spending 30 minutes on the wall at the hospital, this patient goes from viable to less viable to less viable to dead. So we've got to be able to read 12 leads. You don't have to know fascicular blocks. You don't have to know the craziness. You need to recognize symptoms of acute coronary syndrome and a concerning EKG and get them to the cath lab center and get that EKG in front of a doc. Remember, an EKG is also just a snapshot in time. It's just like a blood pressure. One EKG does not mean you're not having a heart attack. One EKG does not mean you're not going to die soon. So if you're 12 leads on somebody and they look like dirt, get one. If it looks great, treat the patient, move to the hospital. A few minutes later, put your cigarette out, get another 12 lead. Repeat them. 12 leads will change. So I'm trying to think, is the time on there? I don't see the time. I actually marked that one off. That's also a 46-year-old female. That was funny. Maybe not. But this was within a couple of hours. This is the first EKG. Now, dude is altered, snoring, respirations, looks like dirt, they say. I bet he does. So in my mind, too fast, too slow, or okay. Too slow, right? Profanity, too slow. I start looking injury patterns and I recognize that is a big freaking STEMI everywhere. All right. So I've looked at that. I've glanced at that. That rate is too slow. Guy looks like death. I peeked at the EKG. It goes to the floor. Hands are on. We're starting a line. He's starting dopamine, maybe some atropine, probably not going to work. I know his previous EKG was normal, so it's probably not hyperkalemia. It's probably not a drug overdose. It's probably acute coronary syndrome, right? In the field with this guy, you could now go straight to pacing. That's category A. Throw the pads on the dude, pace her on, try to capture. Maybe you're rescuing. If your pacer stuff is in the back of the truck, sure, give him some atropine. Probably high-grade heart block, may not work. It may work. There's no harm. Spike dopamine, start running that. If you're used to using push-dose epi, give some push-dose epi. If you're not used to using push-dose epi, don't give push-dose epi because you'll give the wrong dose and he'll go from this to VTAC, which is worse. If your pads are there, pace the dude. Get an airway. A nasty EKG. All right. Questions, comments, statements? Let's take about 5 minutes. We'll come back and talk to them about trauma. Oh, yes, sir.
Yep. So we had a couple of questions come in that were the same question from the beginning of the lecture, and we're getting this a lot. It's a logistical issue. If we're giving acetaminophen, are we giving it with water? With variations on that. Okay, so now we're required to carry water bottles. So when do we give water? When we don't give water?
All official questions about the specifics of state protocol should be directed to the Alabama Department of Public Health, Office of EMS.
Okay, fabulous answer.
Is that good? Yeah, I mean,
Yeah.
Pull the beer out of your own cooler and give it to them. I mean, I'm joking. Don't do that. That's inappropriate humor. Yeah, it is what it is. You have to carry Tylenol. You don't have to carry water. You know, I would not give it as a suppository. Stay away from that orifice at all means.
Strong advice.
Yes, sir. But otherwise, I would, yes.
Okay.
They do. Yes.
Slide one in your bag.
Yeah, or, I mean, if you really need the Tylenol, you can make enough spit and swallow it off of that. But I don't know, sir. Yeah, that's up to you.
Okay.
You're killing me, Chief.
I've had so many people ask. I had to throw it out there.
Yes, sir. Thank you so much.
I'm sorry for that one.
Yeah.
The other one was we had a couple that were related. I'm going to kind of try to morph those into the same question. So it's kind of like we got scarbosa for left bundle branch. So what exactly is different for right bundle branch?
Nothing. The only thing I would say is that if they have that ST depression in a complete right bundle in V1 through V4, then it makes you less concerned. That patient, I'm still going to find the doc when I get to the hospital, show them the EKG. If they're having acute coronary syndrome symptoms, I'm still going to treat them like that. They get aspirin, IV, O2, maybe a nitro. But in my mind, I'm thinking, okay, this is a complete right bundle. This is probably okay. The benefit of understanding that is, now if you have somebody that has a right bundle, but they don't have that T-wave inversion, that tells you that they're maybe having a STEMI because now that ST elevation is elevated. Does that make sense? So that should, right, so that should make you more uncomfortable and make you want to call in advance and say, hey, I got a guy with the right bundle. He doesn't have ST depression anteriorly. I think this is a STEMI. And that gets you moved toward a cath lab faster.
So the specific question was right bundle branch block with ST elevation and the inferior leads
Okay.
with discordance, STEMI question mark.
Yeah, so don't think scarbosa and right bundle. If you got ST elevation inferiorly in a right bundle, it's a STEMI.
Doesn't matter.
Doesn't
if it's
matter.
Discordance or concordance.
Yes.
I think that was the crux of
Yes,
several
sir.
questions.
Yes.
Okay.
And I would argue that if you're concerned, you think the EKG is a STEMI, send it. Take a picture, send it to your hospital, plan for the worst. If it's not, learn from that patient that time, and next time you'll get it. I'd rather you overcall than undercall.
Awesome. Well, hey, everybody.
All right.
We're going to take about
Cases more than just talk anatomy and stuff, but I think this time I got more anatomy type pictures, and then we'll do some scenarios this afternoon, and then we'll build upon this. And I guess in August, the next fourth Wednesday, about some more cases with trauma. You could spend a whole day on chest trauma or abdominal trauma alone. So anatomy, obviously we have a rib cage, we have a sternum. It's pretty firm. If you have someone who has a sternal fracture that you pick up on your exam and trauma, you should be concerned for major underlying injuries. What sits behind the sternum? The heart. Yeah, right. So if you break that sternum, there's a chance that you can lacerate vessels behind there. You could damage the heart, but you know there's a lot of force, right? So sternal fractures should make you uncomfortable and make that patient get quickly to a hospital and think about underlying injuries. When you think about chest wall exam, if I have a patient who has blunt force or penetrating trauma to the chest and they're ill, they look ill on my primary exam, I'm going to expose them, get them naked. I'm going to look at that chest wall for soft tissue injuries. I'm going to look for holes, for injuries, things that can hurt them. I'll make a joke about anybody that's critical, you expose them, you look for holes, patches, tattoos, anything, right? So you look for those things. You can have gloved hands. You can do a quick assessment. If it's dark, you can run your hands down their back looking for blood. You're going to palpate and squeeze. If they cuss you, you know something hurts. That's a sign of an injury, right? You can feel for crepitus, subacute air, for movable parts, all right? So those are the things that you're thinking about. But you have the sternum, you have 12 ribs. First rib's really hard to find. You got the clavicles. Clavicle fractures that are isolated or unconcerning, but there's no way to know if they're isolated clavicle fractures in the field. So a clavicle fracture, in my mind, for pre-hospital, is you should consider that as just as concerning as a rib fracture. It's a chest bone that broke, and there are important things in the chest cavity, okay? Remember, the diaphragm is the primary muscle of respiration or ventilation. It's a very thin muscle that runs below the rib cage. Increased intra-abdominal pressure can cause that thin muscle to rupture and you get a diaphragmatic hernia. The other thing is you can have abdominal trauma up to the anatomical nipple line, right? So anything anatomical nipple line or below could be abdominal, right? Could also be chest. What is this? Oh, semi-inappropriate humor. Oh, this was talking about anatomical nipple lines, not actual nipple lines. Sorry. Moving on. Intercostal vessels. With the ribs, remember that you have these bundles of nerves, arteries, and veins, and they run above or below the ribs? Below, yeah, right. So that comes into play when you think about when we do chest decompression, we try to avoid going under the rib. We don't want to damage those. But it also comes into play when somebody has busted ribs. So dude's hit with a baseball bat across the chest, and he's got multiple rib fractures on one side. You can assume that he's at least got some laceration to these vessels, and he's going to be bleeding into the skin. You may see a hematoma, or worse, he's bleeding into that thoracic cavity, maybe getting a hemothorax or something of that nature. So the chest wall is pretty vascular. Lung anatomy, you have the trachea that goes down to the carina, and that's where the left and right main stem kind of branches off, and then it goes into the lung itself. You got the two pleuras, you got the parietal, which is the outer layer, the visceral, which kind of covers the lung itself. I think of this as kind of organic saran wrap, because I'm from Mississippi, and that's how we think in Mississippi with saran wrap. Never mind. So in theory, the two saran wraps touch, and there's a fluid between there that separates it. So when you breathe, those things slide along greatly. If there was a broken rib and you tear that saran wrap on the parietal side, let's say, that fluid kind of leaks out, blood may leak in, all right? You get a little air in there, now those lungs don't move as much. And then you can fill up that space, that potential space with air, with fluid, and you can get a pneumothorax where the lungs are collapsed. All right. Also, other chest anatomy, heart is midline, the mediastinum, which is vessels, and also the esophagus is there. Esophageal injuries we don't talk about a lot because we all hope that you never have one. Esophageal injuries don't kill you immediately, but esophageal injuries are hard to find by imaging. They also are very hard to repair because of everything that's around it. And the other problem is if people have unrecognized esophageal injuries in the hospital and they start taking PO, they would get infections into that mediastinal space or into the lungs. And when you start getting your Wendy's burgers and things like that in there, people get pretty infected. Esophageal injuries are usually fatal, unfortunately. Not the day of, but weeks down the road. We talked about the vascular bed. The chest wall is extremely vascular. The heart is below the sternum. Above the heart is the great arch, the aortic arch. So any injury in this area in the box, penetrating or blunt, is concerning for something that's life-threatening. A lot of times we don't even see those in the hospital. They die before they get to us. We also have the venous system, not just the aortic arch, but we got the superior vena cava and inferior vena cava that brings blood back. The pericardial sac is a fibrous structure that surrounds the heart. It has a potential space and some fluid so that when the heart beats, it moves freely. If we get penetrating injury around that sternum in that box that damages that pericardial sac, you'll get bleeding in there. And it can compress the heart and cause tamponade, sort of like a pneumothorax is in the lungs. We call it a tamponade in the heart. And that's not good. Without your heart, you die, right? Fibrous structure. And then when you remove that, you can see you have the vessels. Remember, the heart is not like we see drawn in cartoons. The right side of the heart is the most anterior. So blunt trauma usually affects the right ventricle first. People who are shot or stabbed or jugged in the chest, that right ventricle is usually hit first. Goes through the pericardial sac, into the ventricle. You get blood from the outside going into the pericardial space, making a tamponade. Then you also get blood leaving that right ventricle, going into that pericardial space at high rates, and you get tamponade. People who come into the ED with penetrating box trauma, and they go into cardiac arrest, we try to treat things quickly that we can manage. So we decompress both lungs, hoping there's a tension pneumothorax there. If that fixes it, great. They get chest tubes. We image them. They go to the OR. If that doesn't fix them, then we do a finger thoracostomy where we make an incision, put a big tube in or a finger in, open it up, try to get air out. If that doesn't work, we open up the chest cavity and we look at that pericardial sac. And if it's big and full of blood, we just take a pair of scissors and snip it with the hopes that we get that blood out of there. The tamponade is released. If we can see an injury in that right ventricle, you can put a stitch in it real quick, or sometimes you get a med student and put their finger in that hole and they go to the OR and get that fixed. In the past, you'd see some of the older folks, when we used to have like Caraway, the docs would do those in the field. In reality, you got to have an OR pretty readily available, and you got to have a lot of blood products available as well. But that's what an open thoracotomy is. I tried to put some of those on the lectures, but YouTube says I'm too young to watch those and won't let me load them. Y'all can Google those. In August, if you're interested, it's the I think it's 24th, 25th, 26th. It's a Wednesday, Thursday, Friday, the last of August. I'll have a cadaver lab in Birmingham. It's free. If you're welcome to drive up, make that drive. We'll be able to do chest tubes, decompress the chest, IOs. I may have a donor that's completely preserved. We can look at the heart, but if not, we can do procedures. In November, I will have another lab that will have a preserved body, that the heart will be dissected out, the lungs, the brain, everything. We can talk anatomy there as well, if you're interested. Yeah, sure. I'll be happy to do that. Yes, sir. Yeah. It'll be on Facebook, and I'll send it to the region as well. The thoracic aorta is a ginormous vessel the size of a garden hose. Remember, the aorta is muscular, where the vena cava is not. It's also tethered up near the top of the heart. So rapid deceleration from MBCs or falls, you twist that aorta, and people will get tears. If that thing tears and it's a complete tear, you probably got about 60 seconds before you bleed completely out. Most of these folks die on scene. If you have a partial tear, you can make it to the trauma centers and maybe have some work done. But this is just an angiogram, a recreation off of a CT that just shows how much vascular space we got there. So anything midline chest can cause some pretty significant bleeding. Even if it's not the ascending aorta, even if it's not a tear over here from rapid decel, a stab wound that jacks up some of these pleural arteries, or that carotid artery that's way near the heart, obviously people can bleed out. They lose volume, they bleed into that pulmonary space, maybe get a hemothorax. Chest injuries are bad. This is just a CAT scan picture. I got several of these. When you think about CTs, these are slices of the patient, like you're slicing a lime, right? The patient's head is that way, their feet are going that direction, and they're looking up. This is nice because the radiologist puts an arrow to point where I should look to recognize the patient's in bad shape. I like arrows, right? Like, oh, that's not good. That's what I thought. Yeah, I saw that, right? But this is where you have the white is contrast being squirted in through an IV. So the white is contrast in that aortic vessel, and you can see how it's leaking out. So we have an aortic injury. So when I see this in the ER, I use profanity, and I probably already recognize the fact they have significant mechanism of injury. The chest is unstable. This person needs a vascular surgeon probably 15 minutes ago. Very bad. This is just a quick schematic of how we look at x-rays, if y'all are interested. These are the diaphragms. It's a thin muscle behind the diaphragm, or kind of encapsulated over the diaphragm, is an organ on this side of the body. What organ sits there? Y'all use it every Saturday during football season? The liver, right, right. The stomach is over here. There's an organ over here that we always are concerned about injuring in car wrecks or abdominal trauma, the spleen and the diaphragm, the heart, stomach, vena cava, lungs. Kind of gives you an idea what we're looking at. An x-ray gives us some information. It's not exact. It's like an EKG. It's a screening tool. You can miss things, but you usually pick up the big bad things that you got to fix now. This is an x-ray of somebody who was a high-speed MVC. You can tell they're intubated. You can see there's plastic in the airway up there. It's like there's a G-tube going down too. That's what that white stripe is, so we can find it. So they've been intubated because they were probably altered. We put a gastric tube in to decompress the stomach. All right, we shoot an x-ray and we're looking to see, are there rib fractures? Is there a pneumothorax? And I look and I say, holy crap, that mediastinum is way too wide. Something's going on there. So I think if you have that wide mediastinum and you're bleeding in that space, you probably have an aortic injury. Makes you uncomfortable. This is a CAT scan, but instead of looking at them laying down, they're sitting up. And you can tell there's air over here, which is what you want, because that's what should be in the lung. There's no air over here that is full of blood. And if you look, you see this aorta is torn. So this is a guy with a major aortic injury bleeding into the side of his chest. The question now is, what do we do with this? So you put a chest tube in that and you drain the blood out, he breathes better. But if I put a chest tube in there and that blood comes out, the tamponade, the tourniquet, the natural tourniquet that may have slowed the bleeding down is now gone. So now he may bleed out. So the point of that is you're doomed if you do, you're doomed if you don't. Bad injury, right? So this person needs to be at a place that has a thoracic or a trauma surgeon that can go in and fix that. I'm not a surgeon. I can't fix it. I can recognize it. I can suggest they go to the OR. But if I take you to the OR, you will die. Sweet. So the lungs, they perform ventilation and oxygenation. Real healthy lungs are actually pretty cool to look at. We don't see a lot of those in the ER, which is good. Get it? See the lungs? Never mind. Pneumothorax is when you have that air that enters that potential space we talked about and collapses the lung. So you get two problems now. You get decreased lungs tissue to ventilate and oxygenate, so they may become hypoxic. They may breathe faster to help with the oxygenation and ventilation, right? And then the other problem with this is that if you get a lot of air in here, it decreases or increases pressure in the chest, which decreases the blood that go back to the heart. So you'll see him drop the blood pressure. What happens when you put somebody on CPAP? So you got a guy that missed dialysis, his blood pressure is 220 over 150, they're breathing 80 times a minute, they're hypoxic, you recognize they got crackles, you put them on CPAP. What happens to their blood pressure? It lowers it. Same thing, except it's not really the good CPAP because we're not helping them oxygenate, we're making it worse. So think of this as jacked up CPAP, lowers blood pressure, right? And if they have broken ribs that damage the lung, the air's leaking out, they're probably bleeding, they're probably hypovolemic, so that's to make them even lower blood pressure. So pneumothoraces can be bad for people. What things would you look for clinically to see if somebody has a pneumothorax? What would make you define a pneumothorax on somebody? So maybe diminished breath sounds. Right. Yep. Right. So who here actually uses a stethoscope? Who's actually truthful saying they use a stethoscope? I still got a few hands. Okay, good. Roll Tide. Yeah, all right. Yeah. So diminished breath sounds. Okay, sometimes it's hard to hear those things in the field. I get it. Other ways you can tell, chest wall trauma. So if I'm palpating the chest and I got crepitus, they call my mama names when I touch the right side of the chest. I'm thinking they got busted ribs, probably pneumothorax. If the respiratory rates are increased or diminished, if they're hypoxic, okay, I'm thinking pneumothorax as well. Somebody mentioned JVD. You can get JVD because of increased intrathoracic pressure. My JVD reading skills outside of the ER, where I have bright lights and my glasses on, are pretty limited. So in the field, I'm not looking for JVD because the other thing you got to have JVD is you got to have a regular blood supply. And if you're hypovolemic, even with increased intrathoracic pressure, you're not going to see JVD. So, yep. Yeah. That you got to go into tension. Yeah, right. So my definition of a tension pneumothorax is first you got to have a pneumothorax. So you got to have a mechanism of injury that makes you think they have a collapsed lung, blunt or penetrating trauma, okay? And then the next thing they got to have is they got to have signs of cardiovascular compromise, right? So I define that as they're altered and they either have decreased blood pressure, increased heart rate, something else going on, or they have a pneumothorax and they're in cardiac arrest. That's cardiovascular compromise as well. If the dude's talking to me inappropriate, he probably doesn't have attention, okay? If he calls me a name when I decompress his chest, he did not have attention. Right? You can kind of see there's a small collapsed lung here. This is lung, that's free air, a little bit of air in the chest wall. And you're right, if somebody has a pneumothorax and you bag them, or they're altered and you intubate them and you ventilate them, you increase the amount of air being forced in, you can make that pneumothorax bigger. So chest decompression for a tension pneumothorax in our state is category A, but they got to have a pneumothorax and they got to have tension. The other category A for needle decompression is if they have a flail segment and you got to ventilate them. So if I got a dude that's got a flail segment, multiple rib fractures, and I'm bagging him, you can pop that chest even before you get them intubated if you do some positive pressure ventilation, because you know when you intubate them and bag them, it's going to get worse and not get better. This is the x-ray. I don't see anything crazy. Lungs look good, diaphragms look fine. Patient had left-sided chest pain, some crepitus, diminished breath sounds. My x-ray still looks good, right? But remember, an x-ray is not perfect. So I'm still thinking this dude has a pneumothorax. We get a CT, and again, head is that way, feet this way, looking up. This is the left side. This is his lung, and you can see at the top portion there, that black, that's just air. So the front part of that left lung had collapsed, he had a pneumothorax, but you can't see it on x-ray because you're looking at them straight through and through. So clinical exam gives you a lot more information than some of our imaging does. You can use an ultrasound and look for a sliding lung for a pneumothorax. Some places are doing that. My fellows can probably do that pretty well. Clinical exam, hands on the chest, feeling for sub-Q air, feeling for crepitus, appropriate mechanism of injury. Are they breathing fast, increased work of breathing? Or are you concerned there's an underlying pneumothorax? Here's another easy one to see. This is what we call a long diaphragm, a lot of air in there. That's the lung. This should be all the way down here. It's not. So if I were to ventilate that guy, he's going to end up with a tension pneumothorax in a couple of minutes. Treatment in the field, first thing is recognizing it. They need aggressive oxygenation, so high flow O2. They also need this treatment done en route to a hospital. You can't fix it in the field. I can't fix some of these things. So I recognize dude has mechanism of injury, got a flail chest on the right, a little bit altered. Yeah, I'm calling for rescue. We're going to load him. We're going to move to the hospital. As I start my IV, place my O2. Okay. Open chest wounds, get occlusive dressings taped on 3 sides. There's some Asherman chest seals, other things you can use. I've used a defib pad before and made a nick in it. Whatever you got. The goal is to let air go out but not go in. If you put a chest seal on somebody and a few minutes later they go into cardiovascular collapse, they go into cardiac arrest, they get worse, burp it, pull it off. That's like doing a needle decompression, okay? Then leave it open if you have to. Tension pneumothorax, when you get so much air that you get all these vessels shift over, you get increased pressure, blood return stops to the heart. It's not so much the fact you have one lung. Lots of folks live with one lung. The problem is all this air. So that's why we decompress to get the air out, to return blood supply back to the heart. Where do we decompress the chest at? What places can we go? Yep, so you can do second, third, intercostal space, mid-clavicular. I like the anterior. It's easy to get to. Even if somebody's really big and chunky, I can push down enough tissue to get a needle through there. You can use the lateral space, but remember, you never want to go below the anatomical nipple line. Putting a needle in somebody's lateral chest wall and it going under the diaphragm does not help them. If you have to force the needle in, it's the wrong hole. There should be nothing in the way. Skin, muscle, under the rib, and there's nothing there but air. It should go in easy, okay? I usually aim for a rib and try to slide over the rib. I can't go in the middle. I can find the rib. I pull the skin down, I poke the rib, I let go of the skin, it slides up, I push it in. works pretty good. They should get better after that. I think my battery's done on my clicker. And I just hit enter, Chief. This is a, there we go. So chest decompression with the biggest needle you got. Do y'all carry the military pins? What do y'all carry for chest decompression here? 14 gauge? Yeah, 14 gauge. Yeah. So the different ones out there, you can use IV needles if you want to. Remember, some of the newer IV needles have a no-flow valve on it so they don't bleed when you start them. So if you pop somebody's chest, it doesn't get better, and using the IV catheter, then you have to put a syringe on it and pop that seal so that the air comes out. We talked about locations. Doctors don't look at this x-ray. We're not supposed to get x-rays of tension pneumothoraxes because it should be a clinical diagnosis. You should recognize the patient has a pneumothorax, right? A mechanism of injury and signs of it. And then they go into cardiovascular collapse, right? But this is what an x-ray would look like. So what side has the problem on this person, would you think? What side is jacked up? Left, there you go, yeah. So this is looking straight on. There should be a heart right here. Heart ain't there. So, and they're still alive. So it's not been taken by an alien. All right. So this is all air. This is the cute little lung. It's been so compressed, it's nubbed up here. Everything is shift over. There's lung, there's heart. Thank you, sir. And all this white stuff that looks like it could be blood or something is really just extra crap from being pushed over. So this is bad. So this is somebody that we should have picked it up. We got tracheal deviation. You see that? Textbooks talk about tracheal deviation, excuse me, and tension pneumothorax, that you can see that. In reality, you see it on chest x-ray. You don't see it clinically, and most folks are kind of fat here anyway. Or you see it when you go to intubate them, all right? You go to intubate this person, it's like, where in the world is the cords? You reach around, and you go, oh, the cords are pointing that way. That's kind of weird. You go, oh. Now remember, they're pointing that way because you got a pneumothorax on this side that's pushing everything over. So, big tension pneumothorax. This is him after I put a small little pneumocath in. So if you look under where it says upright, there's a little tube thing that went into his anterior chest, hooked it up to suction, and now his heart's back in regular place. That lung is inflated. He liked me again after he woke up. A hemothorax is where you have blood in that space, not just air. You usually have a hemo and a pneumo. Define a massive hemothorax is greater than 1.5 liters of blood. After you put that chest tube in, needle decompression will not fix a tension hemothorax. Usually those are fairly rare as well. If we put a chest tube in somebody and we get more than 1 liter of blood out, if it keeps bleeding over the next couple of minutes, they're going to go to the OR. We probably have a pulmonary vessel that's been lacerated and bleeding out. Sometimes in the trauma bay, these guys will put a chest tube in them. They don't get better. We're giving them blood. We're giving them TXA. They're still not getting better. We don't have time to wait. We're getting the OR ready. They'll open their chest up and try to clamp off the bleeding in the lung. Sometimes they'll open the chest up and take that lung and twist it and cut off all blood supply to it so the bleeding stops until they can get to the OR and definitively fix it. It's pretty cool, pretty grotesque too. X-ray, right side of hemothorax, all that white stuff is blood. So a closed pneumo is usually blunt trauma or auto peep, somebody smoking a little bit of weed, they hold it in too tight, they pop a bleb, get pneumothorax, versus a busted rib that lacerates the pleura, causes an air leak. Open pneumothorax is penetrating wound, been stabbed or jugged, air goes in, leaks. A tension is when they have a pneumothorax and signs of cardiovascular compromise, which is either cardiac arrest or ultramental status, and some other sign that cardiovascular system is compromised. So cardiac arrest, pneumothorax, you decompress them. Pneumothorax, ultramental status, low blood pressure, tachycardia, you decompress them. Somebody has a pneumothorax talking to you, you don't decompress them. Make sense? Anybody even care at this point in the morning? Again, blank stares. Yeah, good. All right. Cardiac tamponade is when you get fluid around that pericardial space. It compresses the heart. So therefore, the heart is still beating. You'll see electrical activity. Sometimes the QRS complexes are small, but the problem is there's no room for blood to get inside the left and right ventricle and go to the body. It's a problem. You can see that on ultrasound. You see a pericardial fluid, and the heart's really not doing much. At this point in the game, there's not much you can do in the field with that. As we move forward with EMS and you have ultrasounds, you'll be able to fix that. Fairly simple procedure to put a needle in that if you have an ultrasound. We talked about the diaphragm. Remember, the liver has a large body of blood there at all points. Liver lacerations, penetrating trauma. You can have pretty significant blood loss. The good news is long-term, the liver can heal up pretty good. We can even take chunks of it out. Folks do fairly well with that. Abdominal injuries, kind of think about where the landmarks are and where they're injured. Left side, you think about spleen and kidney, large bowel. Right side, you got liver, colon, intestine. Midline, you got aorta, which kills people, pancreas, and stomach. Right? Lower injuries, you think about into the pelvic cavity, big vascular bed. Remember, the aorta runs down this way. The iliacs come off. So penetrating wounds in that area can be pretty bad as far as blood loss. This is a CT showing your kidneys. It's a little bit deep to see the aorta. The cuts are deep. Spleen, diaphragm. Abdominal assessment, so obviously you can look for signs of trauma. You can expose the patient, look for soft tissue trauma, open wounds. You can lay hands on them, kind of mash. Everybody's going to yell at you. You're feeling for distension, okay? Rectal exam. That's for the hospital. In the trauma bay, everybody used to get a rectal exam. We used to stay away from that orifice too. If they're awake, they can clench their butt cheeks. We don't have to check it. If they're not awake, they're getting a paralytic to get intubated, so we don't have to touch that either. That should have came out. Ooh. Sorry. Hemodynamic instability in abdominal trauma. We can do a quick fast, look for blood, and then go straight to the OR. There are 4 views of the fast, and I got a guy with ultrasound rep coming to help as well, plus the fellows today. We can show you some of this. Looking at Morrison's pouch, the splenorenal fossa, Douglas's pouch, and then under the heart. So what we're really doing is looking for free fluid. So Morrison's pouch is between the liver and the kidney. You can see fluid in the belly on ultrasound. It looks like black. There should not be fluid in your belly. So if you have trauma and we see fluid, we think blood. Now there's some folks, females who have just had their cycle, will get some bleeding sometimes in the belly. And then folks who have alcoholic cirrhosis will have fluid in the belly called ascites. Those guys have it all the time. But in the setting of trauma, if we're looking and we see fluid, we're going to assume that's blood. And that's a big hint. I got blood in Morrison's pouch. Screw it. We're not going to do CAT scans. It's time to go to the OR at this point in the game and fix that. But Morrison's pouch, looking for blood between the liver and the kidney. That's a black stripe. Splenorenal fossa is the left side. That's probably more common if the spleen's involved, but you're looking for blood. Douglas's pouch is around by the bladder. So you should not have 2 fluid collections. You only have 1 bladder. Most people, you got 2, one of them is blood. I talked about location for chest decompression as well. I'm still an anterior approach guy. I know a lot of literature is going lateral. I've seen several pre-hospital decompressions that have gone under the diaphragm. And that makes me uncomfortable. So if you're not sure what you're doing, go laterally. Remember, air, if your patient is laying on the back, air is going to rise. So the anterior approach should work pretty fine. The goal is to get enough air out so you relieve a tension, not fix the pneumothorax. That's probably not going to play either. All right. So 46-year-old male, he was shot to his shoulder. Heart rate's 80, blood pressure 118/60, breathing about 24 times a minute, set 93%. A little bit diaphoretic. Concerned or not concerned? Yeah. So what makes you not right now concerned? Yeah. So right. So if you look at his vital signs, they look pretty good. 84, that blood pressure. I'd pay money to have blood pressure like that, right? He's a little bit tachypnic, but he just got shot. I'll be breathing fast too. Stats are okay. I would argue that he's sweating like a pig, right? I guess pig sweat. That's a phrase. All right. So why is that? And I'm gonna say, dude shot in the shoulder, which technically the shoulder is the chest cavity, and he's diaphoretic. I would be concerned that he has hemorrhagic shock about to happen. Why is he not tachycardic? Maybe he is on a beta blocker, calcium channel blocker, maybe he's a hypertension medication. All right. Blood pressure 118/60. In the deep south, that is almost hypotension anyway. All right. How many people do you see with that good blood pressure? Not many, right? So this guy makes me uncomfortable. So this guy is going to get a quick cursory exam. I'm calling for the soft stretcher, something to get him to the rescue. I'm going to do a quick listen. Somebody's starting IV access. I'm throwing high flow O2 on him. I'm starting IV access, and I'm probably going to go ahead and give him some medicines. What medicine would I give him as I start moving to the hospital? I would argue TXA. So the state protocol state they got to be altered, or they have to have either altered hypotension, tachycardia, and there's a caveat, or other signs of cardiovascular compromise. And I'd say sweating is. I had a guy in Birmingham that back in the fall that was shot in the back. He's laying there butt naked on the street. It's 40 degrees. I'm freezing in a jacket. His heart rate was in the 80s or 90s. Blood pressure was fine, but he's just pouring sweat. That's not appropriate, right? Maybe he smoked some crack. That's why he's sweaty. I don't know. But he's also got, high-speed lead poisoning, right? So he gets TXA. I assume the worst. If I'm wrong, all's good, all right? If I don't assume the worst and I'm wrong, dude could die. So I expedite transport, he gets TXA. A lot of vessels in the shoulder, right? Other thing to think about, folks hit with small caliber weapons across bony prominences, those the bullets can ricochet and go from the clavicle or the scapula into the esophagus, into the lungs, into the heart. You just move all around. So dose of TXA is 2 grams. If you only have 1 gram, so be it, but they get 2 grams. High flow O2, IV access. And this is the high-speed lead poisoning bullet, a lot of blood in his chest. Remember, TXA doesn't fix you from not bleeding. TXA works as an antifibrinolytic. So basically, your body makes a clot when there's a vessel that's damaged. A few minutes later, the body sends things there, proteins, and it says, do I need to keep this clot in place or can I break it down and use these molecules somewhere else? So it breaks the clot down, you're still bleeding, it makes the clot again. And it does that repetitively. And the problem is the more it does that, the less it's able to clot off that bleed. When you give someone TXA, it tells the body, screw it, I'm gonna keep your clot no matter what you say. So that one clot stays and gets bigger and it prevents bleeding. Ideally, after TXA, they get blood or plasma products. Those are going out to some place in the state right now. The flight crews have them, some ground agencies are applying for it. But for the most part, TXA is out there. It's relatively available. It's cheap. If you don't have it, I'd recommend you getting it. 22-year-old shot in the chest. Heart rate's 143, blood pressure 90, breathing 32 times a minute, diminished breath sounds. En route, he becomes altered. He starts breathing down. What do you do for that kid? Decompress. Yeah, I would say he is now altered. His heart rate's decreasing. That's concerns for attention. How do you confirm that clinically? Well, he has a pneumothorax and signs of tension, so clinically you proved it, so who cares? He has high flow O2, you decompress the chest, you're giving your TXA, you're letting the hospital know, I just popped his chest so that when we get there, or when you get there, we're ready, set up for a chest tube, right? And on that note, for chest decompression, remember that cardiac arrest in a non-traumatic patient, 60-year-old person, you put your Lucas on or you do chest compression for 15 minutes, you get ROSC back, you get them tubed, they probably have broken ribs, correct? And if they go back into cardiac rearrest, they're hard to ventilate, they're hypoxic, you assume they have a tension pneumothorax as well. You can decompress medical cardiac arrest as well. If they have risk for pneumothorax, you think they have it, then signs of tension.
Listen.
Yep, it depends. So if I got a guy that's shot in the armpit, goes in cardiac arrest, I'm probably going to tube both sides, start with TXA, get an airway, then reassess what's going on. You know what I mean? Because you never know where it's going to be. Just more pictures. The chest is pretty vascular. This is a lateral view of a CAT scan showing the fact that that bullet went through and did pretty significant damage to the lung itself. This is a quote that I put on a lot of the slides that we do, a lot of the classes we do. The point being, we take care of a lot of people. We do a lot of care that is not emergent. I get it. We have frequent flyers. We have the knee pain since 1972. But if you don't do a good exam, if you're not diligent, you're going to miss the stuff, the reasons we got into this job. I sell these pictures pretty frequently as well. These are at not Dollar Tree. What is that? Five Below. You got a Five Below down here? Yeah. So there's a doctor, there's an EMT, there's a nurse. All right. But if you notice, the doctor has bigger arms. Just so you firemen know that. Those doctors have bigger arms. That's why I went to med school. All right. And then the other thing I show this picture here is, calling paramedics or EMS providers, healthcare providers, is like calling this dude a day laborer, right? So yeah, he's doing the day labor part, but he's doing it 13 floors off the ground, standing on rebar while everybody else is watching, holding him. So one of my goals with EMS Challenge is to try to get more physicians, nurses, hospitals, be the support group for you guys to give you what you need to take care of patients. A lot of healthcare is being pushed out to the pre-hospital, out-of-hospital scene, and we got to do it better. So that's one of the goals of this program. I got 3 rules that I try to live by. I don't kill people because I can't go to jail. I'm too cute. I try and help people do the right thing, and I want to go home with a clear conscience. And I accomplish those 3 goals by being diligent, by training, by preparing, by being ready for that cardiac arrest or that significant patient, and not being lazy, okay? The things that we do, the medicines you carry can hurt people, but can also save them, right? There's some things I can't fix. I can recognize somebody has a head bleed, but if I take them to the OR, they're gonna die. But my job is to get on the phone with that neurosurgeon and make them come there. Just like you can recognize a STEMI, but you can't lice it or do a cath lab, but you can recognize it, get to a hospital, and find that doc and follow him around and poke him on the shoulder and keep showing the EKG till he goes to the patient, all right? Questions, comments, or statements? Enough ramblings. Within reason. Any inappropriate jokes we can share online?
Well, we got a couple of those have already come in, and I've already published them.
Okay, good.
The first FYI, which I appreciate, is that pigs don't sweat. They have no sweat glands. That's according to Anonymous. So I'm sure that's
probably somebody from Arkansas, is what I'm thinking. Yes, see, I knew it. It was you. Yes, thank you. All right, sorry. I do like pigs. I like ham.
So we also had one that got texted in with the introduction of ultrasound in the pre-hospital setting. Do you foresee a time of doing pre-hospital pericardial centesis? I
think that is very reasonable within ultrasound. Now, ask me how many times I've had to do that in my career.
How many times have you had to do that?
Like 3 times. So it's not a common occurrence, but yes, when it needs to be done, it needs to be done. Ultrasound is going to change a lot of things. You can find pneumothorax. You can get a positive fast. If you work in an urban center where you have a couple of trauma centers, not a big deal. You're going to take your belly pain, MBC to the hospital, right? If you're working somewhere where you got to decide, do I drive 40 minutes to a level 3 trauma center, which is, right? Or do I call an aircraft to fly somebody 40 minutes to a level 1? And ultrasound could make a difference. So yes, I think it's going to change a lot of things. And they're cheaper now. You know, 5-10 years ago, it was 20 grand. You can get a butterfly for 2,000. The one that I brought today, which I do not sell, I can't remember the name of it. Don't tell the guy. It's about 6 or 7 grand. I brought it to Enterprise last time. It works pretty good, and it's got a cheat button. It's artificial intelligence. You hit the cheat button, and it labels anatomy. It says that's the spleen, that's the liver. It doesn't say it, but it shows it to you. What else you got? If you're in the Troy area, we're going to do skill labs in about an hour or so.